you suffer from adult polycystic kidney disease, then probably you're in trouble. See what I said there? You're in trouble. Hello everybody, it's Ryan here. I hope you and your family are well. Today we're tackling polycystic kidney disease. I encourage you to smash that subscribe button. Here's the outline of our talk. We're going to be addressing a clinical question as always that kind of gives us some context behind the topic of discussion. Then we're going to tackle adult polycystic kidney disease. We're going to cover headline key points first up, then an introduction, and then we're going to break down etiology, patient presentation, looking at pathophysiology and risk factors, look at a reasonable differential diagnosis, talk about investigations and diagnostic evaluation, treatment and management, and then we're going to end off with prognosis and complications and encouragement from scripture. Hope you and your folks are well. Thank you so much for joining me. Okay, let's cover key points first, guys. Polycystic kidney disease is a hereditary disorder of renal cyst formation, which causes gradual enlargement of both kidneys, sometimes progressing to renal failure. Almost all forms are caused by a familial genetic mutation. Symptoms and signs are going to include flank and abdominal pain, hematuria, and hypertension. How do we diagnose? By CT or ultrasonography, and treatment is symptomatic before renal failure. And of course, if renal failure supervenes, then we use dialysis and transplantation thereafter. Let's go, guys. Which of the following is an extrarenal manifestation of autosomal dominant polycystic kidney disease? Is it A, aortic regurgitation, B, aortic root dilation, C, colonic diverticular, D, intracranial aneurysm, or is it E, all of the above? Okay, guys, polycystic kidney disease accounts for 2 to 4% of incident end-stage renal disease in the States. It causes principally, it's caused by two major disorders. So we got the autosomal and the recessive. The autosomal and the recessive. Autosomal dominant polycystic kidney disease called ADPKD, and autosomal recessive polycystic kidney disease, ARPKD, right? So autosomal dominant variety progresses to end-stage renal disease in at least 50% of patients by the time they turn 70 years old. So all not that uncommon. The recessive form typically results in end-stage renal disease before age 15. As such, it is generally diagnosed and managed in infancy or in childhood, right? Let's look at etiology, epidemiology, and risk factors. So autosomal dominant polycystic kidney disease is caused by a mutation in either one of two autosomal dominant genes, either chromosome 16, which we call PKD1, or chromosome 4, which we call PKD2. Now, these genes encode our beloved polycystins, the exact functions of which are but unclear, still yet to be determined, but may be important in the functioning of cilia. Now, patients who have PKD1 and PKD2 mutations are similar, but progression to end-stage renal disease is quicker with PKD1 mutations. Disease from PKD1 mutations usually present clinically in the 4th or 5th decade of life and can be detected by ultrasound or CT scan. ADPKD affects 1 in 500 to 1,000 people. However, many affected individuals will never go on to develop the clinical manifestations during their lifetime. Okay, focal clusters of cysts do not develop until adulthood. It's postulated that a two-hit process is required for cystgenesis, and that an inherited somatic mutation in conjunction with a randomly acquired mutation in the second allele is required. Family history is present in upwards of 60% of cases. ADPKD is caused by mutations on chromosome 6 and involves more tubular segments. It may lead to perinatal death and frequently causes renal failure in childhood, right? So here's a beautiful diagram taken from Harrison's, and here we are looking at the schemata of the primary cilium and cystic kidney disease protein. So on the left, this beautiful diagram here shows us a scheme of the primary cilium. So primary cilia share a 9+0 organization of microtubular doublets. Proteins are transported into the cilium by motor protein kinesin 2 and transported out of there we have motor kinesin 2 and transported out of the cilium by dynein. The cilium is connected to the basal body through the transition zone. So in the middle, we're talking about the topology of ADPKD. That's autosomal dominant polycystic kidney disease, talked about the PKD1 and PKD2 mutations, and autosomal recessive polycystic kidney disease, speaking of the PKHD1 mutation. Right, so these proteins, polycystin 1, polycystin 2, and FPC are shown. Localizations of disease proteins in the cilium, the transition zone, and basal body are color-coded. Okay, another right, we're looking at potential disease mechanisms due to cilium-mediating signaling events. So we have extrasignal signals, uh, which are propagated by the receptors, and then we have a variety of mediators, defects in which cause manifestations of disease, together with planar cell polarity, cell proliferation. During development, morphogenesis leads to severe disease and early quick onset. Post-development maintenance leads to mild disease and late or slow onset. Okay. Guys, patient presentation. How do patients with polycystic kidney disease present? Some of them present with flank or abdominal pain. They can come in with increased abdominal girth and a palpable abdominal mass, may be present due to cyst enlargement or infection. Markedly enlarged kidneys with multiple bilateral cysts, gross hematuria, frequently associated with hypertension and progressive kidney failure. It is believed that enlarging cysts may compress afferent arterioles, which then leads to increased renin secretion, and that's the basis of the hypertension. Concomitant things you may also find in these patients are hepatic cysts, intracerebral aneurysms, aortic aneurysms, diverticulosis, and abdominal or inguinal hernias. Urinary tract and cyst infections are common, and also there's an association with nephrolithiasis. A plausible differential, guys, are multiple simple cysts, acquired cystic disease due to chronic kidney disease of any other etiology, tuberous sclerosis, von Hippel-Lindau disease, renal cell carcinoma, and nephrolithiasis in adolescents. Now, guys, if you do an ultrasound of the kidneys and you find enlarged kidneys, if you don't necessarily find cysts, but you find enlarged kidneys, there's a broad differential. It could be diabetic nephropathy. It could be amyloidosis. It could be renal vein thrombosis. It could be acromegaly. It could be bilateral hydronephrosis and hydroureter, among others, right? So guys, how are we going to work up patients with polycystic kidney disease? So first up, the basic tenets of medicine: history and physical examination. Often you find that a positive family history is present, so inquire about that. Renal imaging via ultrasound or CT reveals enlarged kidneys with multiple cysts. Diagnostic criteria are based on the presence of a family history of polycystic kidneys in genetically related family members, as well as the number of cysts that you detect via imaging. The criteria, importantly, vary with age and are most applicable to the PKD1 mutation in ADPKD. If you are younger than 30 years old, you need to have at least 2 cysts, which is uni or bilateral. Between the ages of 30 and 59, you need at least 2 cysts bilaterally. If you're older than 60, you need at least 4 cysts in each kidney. A normal ultrasound after the age of 30 virtually excludes autosomal dominant polycystic kidney disease in persons with a family history of a PKD1 mutation. In families with a PKD2 mutation, a normal ultrasound by age 30 virtually excludes ADPKD in individuals with a family history of a PKD1 mutation. In families with a PKD2 mutation, a normal ultrasound by age 30 does not exclude later development of disease. Secondly, diagnostic criteria include cysts elsewhere, so polycystic liver and or pancreas, renal failure, and cerebral artery aneurysms. Now, DNA linkage analysis in at least 2 family members is more than 99% accurate, but is expensive and is really necessary. Genetic testing, as we know, is very expensive and may be falsely negative due to a large number of known and still unknown mutations. MRA, which is magnetic resonance angiography, or CT angio to screen for asymptomatic intracerebral aneurysms, is a good idea and is generally reserved for patients with a family history of this complication, persistent or severe headaches, so symptoms, and or associated neurological symptoms. This is what multiple cysts in the kidney look like. A photograph showing kidney from a patient with autosomal dominant polycystic kidney disease. The kidney has been sliced open to expose the parenchyma and the internal aspects of the cysts. Guys, how are we going to treat and manage this? So obviously, if you got cyst-related pain, you want to give analgesia. If you have infection, and if you have stones, you want to aggressively treat those. Angiotensin converting enzyme ACE inhibitors and angiotensin receptor blockers ARBs are the agents of choice to manage any associated hypertension. You want to manage the complications of chronic kidney disease, example, metabolic bone disease, acidosis. As we know, there's a whole variety, a whole truckload of complications of chronic kidney disease. To mention a few, you got issues with volume overload, acidosis, neurological sequelae in the way of peripheral neuropathy, anemia on the basis of diminished erythropoietin production, uremia, and the attendant problems with uremia. You may even have hematological issues. You may have bone mineral disease. You may have malnutrition. You may have dermatological issues as well. In selected cases, cyst unroofing may be necessary for management of pain and recurrent infection. All right. Now, cyclic AMP is involved in cyst growth. Clinical trials are currently underway with tolvaptan, which is a vasopressin inhibitor, which is a V2 receptor blocker, to decrease cyclic AMP levels within the renal cyst, right? Dialysis or kidney transplantation obviously is mandatory or necessary if renal failure progresses. Nephrectomy may be required for management of pain and recurrent infection. This is typically delayed until after we initiate dialysis or transplant. Now, if cerebral aneurysms are present, prophylactic repair is typically recommended if the size is larger than about 7 to 10 millimeters. That's the cut point we use. Consultation with both nephrology and neurosurgery is recommended to determine management and rescreening strategy. Genetic counseling is available for patients and family, and screening should be considered after the age of 18, right? Prognostication and complications, guys. End-stage renal disease develops in about 45% of affected patients by the time they turn 60 and at least half of the patients by age 70. Persistent urinary tract or cyst infections may accelerate the progression of end-stage renal disease or progression to end-stage renal disease. The PKD1 mutation is associated with a greater incidence of gross hematuria and earlier development of renal failure. ADPKD patients do quite well following transplant, and there is no risk for disease occurrence in the renal allograft. There does not appear to be an increased risk of renal cell carcinoma in ADPKD kidneys. Coming back to our clinical question, guys, which of the following is an extrarenal manifestation of ADPKD? Dum, 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 dum. All of the above, indeed. Now, although the most common manifestations of this condition are renal cysts, hematuria, UTI, and occasionally renal stones, there are several common extrarenal manifestations. We spoke about these: intracranial aneurysm, aortic root and annulus dilation, valvular heart disease, including aortic regurgitation, mitral valve prolapse, right? Hepatic cysts, hernias, colonic diverticular with a high propensity to perforate. My friends, let's talk about the Bible. Why should we be worried or anxious about things? When Psalm 55 verse 22 declares, "Cast your cares on the Lord, and He will sustain you. He will never let the righteous be shaken or let the righteous fall." Matthew 11:28, Jesus himself says, "Come to me, all you who are weary and burdened, I will give you rest." There are indeed a lot of things which tend to cause stress and anxiety, especially in today's fast-paced life and fast-paced society. People are always trying to get ahead. But we should not be worried. We should not be anxious or perplexed, because God is there for us. He will never leave nor forsake you. Let us cast our burdens upon Him and take His yoke upon ourselves. For Jesus said, "Take my yoke upon you, for my burden is easy. My burden is light. My yoke is easy." And we will find rest. All right, these are my references, guys. If you enjoyed this video, I strongly encourage you to smash that subscribe button, like, and share this content. Thank you so much. You can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on TikTok and on Instagram as well. God bless you. We're going to be talking about myocarditis soon. Looking forward to that. Have yourself a beautiful day.